Welcome to this clinical explainer on the structure, dosage, and integration of triple-track therapy for persistent postural perceptual dizziness, or PPPD for short. Today, we're diving right into graded exposure, balance retraining, and the absolutely critical CBT integration that keeps patients on track across their entire recovery timeline.
Just a quick note up front, this explainer is based directly on the comprehensive literature review, Persistent Postural Perceptual Dizziness, Rehabilitation, Triple-Track Therapy, VRT, CBT, and Pharmacotherapy, published by Australian Dizziness Clinics. You can grab that full clinic-ready resource right over at australiandizzinessclinics.com.
So, here's our clinical roadmap for today. 1. The treatment plateau. 2. Graded exposure and desensitization. 3. Balance and CBT integration. And 4. Review and next steps. Let's get right into it.
Section 1. The treatment plateau.
Okay, let's talk about a universal clinical frustration. What do you do when a patient's progress just suddenly stalls out? You know the feeling. Why do PPPD plateaus look like a total treatment failure when they usually aren't? Well, it's vital we ask this right out of the gate, because viewing a plateau as a failure often leads us to abandon a perfectly good protocol way too early. And honestly, the physical exercises themselves are rarely the actual problem here.
The crucial point is this. Plateaus, they're usually just the quiet return of the three perpetuating factors you see right here: avoidance behavior, visual over-reliance, and somatic attention. In the 3P model of PPPD, these are the modifiable factors that literally sustain the illness long after the initial trigger has resolved. So if your patient stalls, a simple review of these specific factors almost always restarts their progress. You usually don't even need to make a single change to their physical exercise program.
Moving right along, Section 2. Graded exposure and desensitization. For this to work, you absolutely must build a specific, progressive hierarchy in collaboration with your patient. Notice the classic path here. You start out in a quiet supermarket during low traffic hours, then maybe move to a busy street, then tackle scrolling screens, navigate crowds and public transport, and finally get back to driving. The absolute golden rule here: you have to score their baseline anxiety from 0 to 10. You should only, and I mean only, progress a patient to the next rung on this ladder when their anxiety scores fall by at least half on 3 consecutive sessions.
Now this brilliantly illustrates that exact process. By mapping the anxiety curve directly over the hierarchy, it becomes crystal clear that PPPD titration is inherently gentler than standard peripheral vestibular rehabilitation. Because PPPD is essentially driven by a perceptual mismatch and threat amplification in the brain, aggressively pushing their symptoms is going to completely backfire. It's like pouring gasoline on a fire.
You really need to emphasize this exact time dosage for habituation with your patients. The right dose during an exposure exercise means the patient's anxiety will rise in the first 10 to 30 minutes. Let them know that's expected. But crucially, it must naturally drop over the next 30 to 60 minutes. If they can track that drop, they are experiencing successful habituation.
But we've got to be super vigilant about a major clinical pitfall here. If a patient's anxiety escalates all the way to a full-blown panic, pushing through it actually reinforces their avoidance and prolongs the recovery. So if they hit panic levels, you absolutely must back off to the previous mastered rung on the hierarchy and reattempt the exposure at a lower intensity. Remember, the pace is always patient-led, even if the progression itself is non-negotiable.
For visual desensitization specifically, optokinetic training uses a rotating stripe drum or scrolling visual backgrounds. You're going to start them seated for just 1 to 2 minutes, short and sweet. From there, graduate them to standing, and finally to maintaining dynamic balance while under visual motion. And real-world translation is a huge deal here. Virtual reality setups, like a VR grocery store, have been shown to produce really measurable changes in visual motion sensitivity.
All right, Section 3, Balance and CBT Integration.
I want you to contrast your approach here. On one side, you're actively reducing their visual over-reliance by using eyes-closed balance exercises and foam surfaces. But at the exact same time, you are forcing proprioceptive reactivation by progressively removing handholds and mirrors. You're basically simultaneously challenging their flawed visual dependence while taking away their stable environmental anchors. That forces their brain to actually trust its somatic and vestibular inputs again.
So how does this build into the psychological track? Well, CBT must run through every single physical session. You don't just do the physical exercises and call it a day. You follow this specific structural flow. First, open every session by reinforcing the neurobiology rationale, so they truly understand the perceptual mismatch.
Next, deliver the physical exposure while actively shifting their attention away from the soma. Restructure any catastrophic thoughts about their dizziness in real time. And finally, always link the session back to their value-driven activity goals.
When you effectively combine the physical vestibular rehab track with the CBT track, as shown in this triple-track convergence diagram, they synergize beautifully. They converge to drive functional recovery across a highly reliable 12 to 24-week timeline. Just keep in mind, if fear avoidance is incredibly severe or if their catastrophic thinking is deeply entrenched, combination care with a formal psychologist almost always outperforms physiotherapy alone.
And finally, Section 4, Review and Next Steps.
I want to leave you with this absolute golden rule. The recovery timeline for PPPD is long, and setbacks, they're a guaranteed part of the journey. When a setback happens, calmly reviewing those perpetuating factors, the visual dependence, somatic hypervigilance, and avoidance, always precedes modifying the actual physical rehab program. Always check the patient's behavior and environment before you even think about changing their exercises.
This explainer covered tracks 1 and 2, but as a source material outlines, in Part 4, we close the series with SSRI and SNRI pharmacotherapy adjuncts and the long-term outcomes data that drive the long view. Understanding how these medications act as first-line medical management is absolutely crucial for building an optimal multidisciplinary approach.
For additional resources, including the full literature review we've discussed today, the super useful clinical cheat sheet, audio overviews, and the rest of this educational explainer series, visit AustralianDizzinessClinics.com. Please subscribe to the channel and leave a rating to support this series. Before you go, here's a question for you. How are you actively integrating CBT into your physical balance sessions right now? Think about that as you approach your next patient. See you in the next explainer.